Hello, I'm Fred Basilico. I'm Physician-in-Chief at New England Baptist Hospital and Chief of the Section of Cardiology at New England Baptist Hospital. And today's discussion will be on cardiac consideration in athletes. Topics for discussion include heart disease in athletes. In fact, athletes can have heart disease and can go unnoticed. The pre-participation examination, the elements that are required as part of the pre-participation examination. How do we determine eligibility to play sports if an athlete has underlying cardiac condition? Some case discussions, and then a review of commotio cordis. So our goal today will be to identify those athletes at risk of sudden cardiac death and exercise-related adverse cardiac events. Also, to be ready for on-field emergencies. This is a video of a soccer player from Spain who, you can see in the middle of the field, collapses abruptly. There are some key points about this video. Number one is the type of collapse. It was abrupt and consistent with a typical cardiac event. Also, you can see that immediately a trained team of medical technicians are on the scene to help the athlete. An event like this on a playing field is very distressful for the team, the coaches, but you can see that the medical team can perform resuscitative efforts, and in this case the athlete was resuscitated and was able to be taken off the field to manage his acute medical problem. Young athletes are the picture of health, yet there are approximately 100 competitive athletes who die of sudden death each year. The real question is how a person who is at the very peak of fitness can succumb to cardiac arrest. Most of these deaths are related to underlying cardiovascular conditions that we will discuss today. The first report of sudden cardiac death occurred in 490 BC with the Persian fleet descending on Marathon, Greece. A young runner named Phidippides was sent as a messenger to enlist the support of the Spartans. Upon return to Marathon, his running skills were once again employed, this time to spread the word of the recent Athenian victory over the Persians. Running over 250 kilometers in 3 days, Phidippides quickly succumbed to exhaustion. With his final breath, he exalted, "Nike, we have won," paying homage to the goddess of victory. Through the years, we have witnessed athletes who've died during athletic competition. Here are some examples of famous athletes. We are well known here in Boston of Reggie Lewis' story, who succumbed to sudden death in the early 90s. Jim Fixx, who was a proponent of exercise and distance running, also succumbed from heart disease while exercising. Ryan Shea, who is a marathoner who is training and competing in an Olympic trial in New York, succumbed to a cardiac event during that trial. And lastly, Hank Gathers, who is a Division I NCAA basketball player, succumbed to a cardiac event while playing a game for Loyola Marymount on national TV. A more recent story, but with a better outcome, is Isaiah Austin, who was a candidate for the NBA draft in 2014. During the NBA Combine, which is a pre-draft event where the medical team from NBA teams around the country converge in Chicago and have athletes go through a complete medical evaluation. In this case, included echocardiography, stress testing, and electrocardiography. It was determined that he had evidence of Marfan syndrome and also cardiac findings consistent with Marfan syndrome, and he was determined to be ineligible to participate in competitive professional sports. He subsequently has decided to continue his career in basketball, but now as a coach. So what are the statistics? In the adolescent and young adults, the incidence is about 1 in 100,000 to 1 in 300,000 high school and college athletes die of sudden death. That's approximately 125 sudden cardiac deaths per year. The ratio is much higher in males and much higher in blacks as compared to white athletes. As far as sports where we are more likely to see events of sudden cardiac death, there are two factors that would play a role here. Number one is the intensity of the sport, and number two is the number of athletes participating in the sport. So in the United States, we see a higher incidence of these events in basketball, football, and track. In the study in France, the athletes have a higher incidence in participating in cycling, jogging, and soccer. When does it occur? Usually in the high school age, but can occur before high school, in college, and infrequently during professional years. The setting is most likely in practice. Athletes spend more time with intense physical exercise in practice than during competition, but there also is some events that occur not in the practice setting and not during competition. Joggers, there's about one death in every 400,000 joggers, which means one death in every, it's one death in every 400,000 hours, which is one death in every 15,000 joggers. For marathon runners, it's about one death in every 50,000 to 80,000 marathoners. And there was a good example here in Boston in 1996 during the 100th anniversary of the Boston Marathon, where there were 50,000 entrants and one athlete died at the finish line. During athletic events such as marathon runners have a five-fold increase of acute cardiac events during the marathon. And if we look at the deaths per person hours for competition versus the average for middle-aged men, there's approximately 15-fold increase of risk during running a marathon. In 2011, Harmon and colleagues published some data from a review of sudden death in NCAA athletes. The most common cause of death in NCAA athletes is accidents. However, there were 16% of these athletes did succumb from a cardiac cause. And this looked at approximately 2 million participants. Overall, the incidence of sudden death in college NCAA athletes is about 1 in 40,000. The highest incidence of sudden death occurred in male Division I basketball players at a significantly high rate of 1 in 3,100 per year. Do the athletes have symptoms prior to the event? Most don't. And if we look at the risk of sudden cardiac death by age and look at what are the underlying causes for sudden death, first of all, we look at that the incidence is low as you're young, but as one reaches middle years, the incidence of sudden death continues to rise. In the younger age group, congenital heart disease is the most likely cause of sudden cardiac death in an athlete. In the older athlete, it's atherosclerotic cardiovascular disease. And throughout the years, there's cardiomyopathies, whether it's hypertrophic or dilated cardiomyopathies. Marin in 2007 published a study looking at the causes of sudden death in a group of athletes. And the most likely cause that was determined at the time of death was hypertrophic cardiomyopathy. Coronary artery anomalies is also a significant cause for sudden death. And then there are other diagnoses that were found, including myocarditis, arrhythmogenic right ventricular dysplasia, mitral valve prolapse, tunneled LAD, atherosclerotic cardiovascular disease, aortic stenosis, dilated cardiomyopathy, sarcoidosis, aortic rupture, ion channelopathies such as prolonged QT, Brugada syndrome, and other congenital heart disease. And this is for athletes under age 35. If we look at hypertrophic cardiomyopathy, this is the most common cause of sudden death in athletes. It is an abnormal condition that is an autosomal dominant where the heart muscle becomes abnormally enlarged and usually the septum is much thicker than the remaining walls, and there is obstruction to left ventricular outflow. Under microscopy, instead of seeing parallel muscle fibers, one sees muscle fiber disarray, and which leads to ultimate hypertrophy at risk of sudden death. Anomalous coronary artery can be of two types. One is an anomalous right coronary artery, where the right coronary artery, instead of coming out of the right coronary cusp, originates from the left coronary cusp. And also there's anomalous left coronary artery, where the left coronary artery, instead of originating from the left coronary cusp, originates from the right coronary cusp. During exercise, both the aorta and the pulmonary artery dilate, and these anomalous vessels traverse between the aorta and the pulmonary artery and can have some torsion on the ostium and cause a slit-like narrowing of the ostium, which leads to ischemia, develop arrhythmia during exercise, and can cause sudden death. In arrhythmogenic right ventricular dysplasia, the pathology is fatty infiltration, usually of the right ventricle, but can extend into the left ventricle. And this can set up a situation of ventricular arrhythmia and lead to syncope or sudden death. So how do these events happen? There has to be a substrate plus a trigger, and the substrate is underlying heart disease, and the trigger is exercise. So if we take, for example, a coronary artery disease, and this is an artist's representation of an unstable plaque rupturing, we can see that in the vessel there's a lipid plaque with a lipid core that has a fibrous membrane and with smooth muscle cells and inflammatory cells. And in this cartoon, you can see that the fibrous cap has ruptured. There's plate adhesions, there's thrombus with partial obstruction, which can lead to ischemia and arrhythmia, or complete occlusion, which can lead to infarction and ultimately leading to a life-threatening event. So how do we determine if an athlete has underlying heart disease prior to allowing them to participate in sport? And this has required us to proceed with a pre-participation examination. And the American Heart Association has given specific guidelines on how this should be done. A careful, complete personal and family history and physical examination is required to identify those cardiovascular lesions known to cause sudden death or progression of disease. It's mandatory. It should be done before participation in organized high school or college sports. Screening should occur every 2 years with interim history every year. For older athletes, we have to think more about coronary artery disease. And so if an older athlete has symptoms, or if an older athlete has one or more risk factors such as hypertension, diabetes, hyperlipidemia, smoker, family history of early onset of heart disease, or sedentary lifestyle, we usually recommend a pre-participation exercise tolerance test. The American Heart Association has a 14-point guideline that is required as being the elements of a pre-participation examination. They include specifics about the medical history, the family history, and the examination. For the medical history, eliciting a history of chest pain or chest tightness, unexplained syncope, and not just vasovagal syncope or orthostatic lightheadedness and syncope, but some unusual syncope, excessive exertional and unexplained shortness of breath or fatigue with exercise. If there's a prior recognition of a heart murmur, if the athlete has an elevated systolic blood pressure, a prior restriction from participation in sport, or prior testing for heart disease ordered by a physician. These are important information to elicit during this examination. Family history, athlete has to be questioned about if their family history of premature death, especially in a family member under age 50. Is there been disability related to heart disease, especially in a family member under age 50? Or is there specific knowledge of certain cardiac conditions in family members, such as cardiomyopathy, whether it's hypertrophic or dilated cardiomyopathy, long QT syndrome or other channelopathies, Marfan syndrome are clinically important arrhythmias. In the younger athlete, it's very important to have the conversation with the athlete's parents who have better knowledge of the family history. As far as the examination, it's recommended that the athlete be examined for a heart murmur, and this has to be done in a quiet room without extraneous noise, and it should be done in the supine and sitting position. Sitting position is important in that it allows pooling of blood in the lower extremities, decrease filling of the left ventricle, and can increase the intensity of the murmur that could be related to hypertrophic cardiomyopathy. One should check simultaneous radial and femoral pulses to check for coarctation of the aorta. Notice if there's any physical stigmata of Marfan syndrome, and also brachial artery blood pressure is mandatory and should be done in a sitting position, preferably in both arms. I also recommend going on beyond those elements and asking athletes about a drug history, cocaine, methamphetamines, anabolic steroids, and also a nutrition history, especially in females. Females can have excessive weight loss, self-induced vomiting, or what's called a female triad, which includes amenorrhea, anemia, and osteoporosis. And any of these could put the athlete at risk of an adverse cardiac event. So what are the limitations of the pre-participation screening examination? We know that an athlete with heart disease can go through this examination and be cleared to participate in sport. And this is well documented by a study by Barry Marion in 1996, where he looked at 134 episodes of sudden cardiac death from athletes. Of those 134, 130 went through a screening examination, maybe not as intense as the 14-point examination, but they did have some screening. Of those, 8 had a correct diagnosis of an underlying heart condition, and only 2 were advised to be disqualified from competition. So that we can see that even with a screening examination, we may not able to pick up all athletes who have underlying heart disease. And so one has to be mindful of this fact, and whenever one is dealing with an athlete, that if the athlete is having symptoms, they need to be further evaluated. The next question is, should a 12-lead electrocardiogram be part of the pre-participation physical examination? And we know that athletes can have abnormal electrocardiograms even if they're healthy and have no underlying heart disease. Here's an electrocardiogram of a professional athlete who has been determined to have no evidence of underlying cardiac disease. And in this electrocardiogram, one can see ST segment changes, ST elevations, T-wave inversions, which appear very abnormal, but are consistent for this athlete as an athlete's heart. In 2006, Corrado and his colleagues published this data of a screening program in the Veneto region of Italy. They looked at the incidence rates of sudden cardiovascular death in screened competitive athletes and unscreened non-athletes ages 12 to 35 years old. What it demonstrates is that the incidence of sudden death in non-screened non-athletes was low, at below 1 death per 100,000. But at the beginning of this trial, the athletes had a 3.5 times increased risk of suffering a sudden cardiac death event. They initiated a program where they had physicians who were specially trained in pre-participation screening evaluate every athlete in the region, and also performed a 12-lead ECG. And they were able to just demonstrate over time that the incidence of sudden cardiac death in the athletic population was at least equal to or even below that of the unscreened non-athletes. And so this was the push for consideration for electrocardiographic screening. The abnormalities that one would look for on the electrocardiogram include Q waves, ST segment depression, T-wave inversions, atrial abnormalities, right ventricular hypertrophy, conduction abnormalities, abnormal QRS axis, prolonged QT or short QT intervals, Brugada pattern, pre-excitation pattern or significant arrhythmia. However, in this country, we have not embraced this approach. It would have to be created from scratch. It would require screening 15 million athletes yearly. The disease we're looking for are very uncommon. The number of deaths is small. The cost would be in the billions per year. And we don't really have the physician manpower to perform this type of a screening program. And then we would also need further resources and costs to evaluate abnormal ECG results. In fact, in the United States, our incidence of sudden cardiac death is actually below what they're reporting on this study of the unscreened non-athletes. And our incidence is about 0.5 to 0.6 sudden deaths per 100,000 person years. So we're starting off at a very low level, and therefore the addition of an electrocardiogram and a more formalized screening program may not be as beneficial as they saw here in the Veneto region of Italy. In September of 2014, the American Heart Association, the American College of Cardiology, came out with new guidelines regarding the use of the ECG, and they've recommended that use of ECG as a screening tool has not been shown to save lives. They strongly recommend, and this is now a strong guideline, that there's a 14-point checklist that we talked about, that it must be included in all athletic screening. If one of those elements of the 14-point checklist is abnormal or positive, then one needs to go on for further evaluation, such as electrocardiogram or further testing. In a study that's been performed here in Boston by Dr. John Corrado, not related to the Dr. Corrado from Italy. Dr. Corrado is a physician at Northeastern University and Children's Hospital here in Boston. He, myself, and Dr. Yim have done a study looking at the early screening for cardiovascular abnormalities through pre-participation echocardiography, or called the ESCAPE study. And the idea was to use a portable echocardiographic machine at the athlete's side during the pre-participation examination as just a brief, quick look study to see if we could determine if there was any abnormality. And essentially, the first study looked at measurements of left ventricular size and wall thickness, and the second study looked at aortic root size, and it compared two sports medicine physicians who were trained to do this procedure on the athlete during the pre-participation examination, and compared it to a trained sonographer. And the findings were that there was very good correlation between the sports medicine physician and the trained sonographer. This is not recommended at this time. This needs to be done in a much wider study involving much more athletes, and also athletes who may have underlying disease. So how do we determine eligibility for competition for our athletes? One of the things that's important that I briefly mentioned before is that the pre-participation examination may miss athletes who have underlying heart disease. So it's very important for us to evaluate any athlete during their participation in sport if they have any symptoms, such as chest pain or chest tightness, shortness of breath, palpitations, lightheadedness, or unexplained syncope. This is, I would consider this mandatory, that the athlete has to stop practice and be referred to a specialist who is particularly trained in evaluating young athletes for underlying cardiac disease. So what we have so far discussed are the history, the examination, and discuss athletes with symptoms. If any of these are abnormal, they would result in an electrocardiogram and possibly go on to further cardiac testing. On the right side of the slide, you can see the types of tests that are available to us, anywhere from stress testing to echocardiography, Holter monitoring, gated plug pool scans. I particularly use often stress echocardiography for certain conditions. stress nuclear, cardiac MRI, cardiac CTA, and cardiac cath. So here's some examples of cases of athletes with cardiac issue. The first case is a 27-year-old basketball player who collapsed suddenly during sports participation during a professional game. In fact, he collapsed on 2 separate occasions in 2 games. He had only brief loss of consciousness and no head injury. And this is the story of Reggie Lewis. His findings included cardiac monitoring, which demonstrated multifocal PVCs and non-sustained ventricular tachycardia. Nuclear stress tests demonstrated anterior wall perfusion abnormality. And cardiac catheterization demonstrated anterior wall akinesis. His coronary arteries were normal, and there was no spasm at that time. We were using ergonovine. Unfortunately, Reggie was practicing by himself at a college facility and collapsed and died suddenly. His autopsy did confirm that there was an anterior wall abnormality consistent with a focal cardiomyopathy, and the examiner's report stated that it was most likely related to prior viral illness. So what do we have to think about in syncope in athletes? Well, there are some more benign diagnoses and differential diagnoses, and then, of course, there are diagnoses that could put the athlete at risk of sudden death. So any athlete who has near syncope or a syncopal event needs further evaluation to distinguish if it's a benign event versus an indication of an underlying serious condition. So more benign type events could be related to vasovagal and neurocardiogenic syncope, orthostatic lightheadedness, especially if the athlete is dehydrated, weightlifter syncope, or breath-holding spells. Sometimes see that with rowers. But also, more serious cardiac conditions can lead to syncope, such as hypertrophic cardiomyopathy, dilated cardiomyopathies, atherosclerotic cardiovascular disease, or anomalous coronary arteries, aortic stenosis, especially when severe, myocarditis, or pulmonary embolus. Moving on to a second case, this is a 22-year-old male college basketball player with recurring non-exertional chest pain, sometimes lasts an entire day. No problems during training or exercise, so it sounds mostly like a chest wall or musculoskeletal chest pain. However, he did go through evaluation, including a chest x-ray and bilateral rib x-rays because they thought it was musculoskeletal. It was negative. He did have a trial of Medrol dose pack, produced no improvement. Electrocardiogram was essentially unrevealing with early polarization and poor outway progression. Echocardiogram was normal, but the stress test was abnormal. Had 2 to 4 millimeters of ST segment depression, but without chest pain. And the nuclear perfusion test was abnormal, with ejection fraction of 40% and fixed and reversible inferior defect. He subsequently underwent coronary CT angiography, which demonstrated an anomalous right coronary artery traveling anteriorly between the aorta and pulmonary artery with a slit-like narrowing, and as demonstrated in this slide. The athlete subsequently underwent cardiac surgery with reimplantation of the anomalous coronary artery into the appropriate right coronary cusp. He recovered from surgery, underwent cardiac testing, post-surgery, no evidence of ischemia, and he was deemed eligible to return to participate in competitive sports. So what about the differential diagnosis of chest pain in an athlete? Of course, most chest pain is related to musculoskeletal chest pain, but one has to also be concerned that there can be an underlying cardiac condition. As we discussed, it could be anomalous coronary artery, it could be coronary artery disease, hypertrophic cardiomyopathy, aortic stenosis, myocarditis with pericarditis, pulmonary embolism, or pleuritis. This is an athlete that presented to my office. He was a competitive bicyclist and would note that during exercise he would have the onset of palpitations, some lightheadedness, but no syncope. So we put him on an exercise treadmill, and during exercise he noted he was getting the palpitations and we were seeing this wide complex tachycardia. And then you can see he was saying, well, this is it. I feel it now, and here it is into this wide complex tachycardia. He went on to EP study and discovered that it was consistent with a right ventricular outflow tract tachycardia, for which he underwent ablation approximately 15 years ago. And I continue to follow this athlete, and he's had no recurrence of this arrhythmia. He's had subsequent atrial arrhythmias, which have required a second ablation, but it continues to do well and continues to compete in competitive bicycling. So athletes can have all types of arrhythmias, and we can even see benign arrhythmias in a healthy athlete. One of our problems is that there can be diagnostic overlap between what's considered an athlete's heart and what can be considered an abnormal cardiomyopathy or a diseased heart. So, for example, there can be left ventricular cavity dilation, and we do see cavity dilation and an athlete performs aerobic exercise such as basketball and running, and that's a normal adaptation to the sport. But also, this can be seen with dilated cardiomyopathy, so there is a gray zone that we sometimes have to deal with. Another area is frequent or complex ventricular arrhythmias, which can be seen with myocarditis, but again can also be seen as part of the athlete's heart. Left ventricular wall thickness is an important finding, especially looking for hypertrophic cardiomyopathy, but this can be a normal adaptation to both static and dynamic exercise. So again, an athlete can fall into a gray area. If we are at all concerned that the athlete has significant hypertrophy and we're not sure, having the athlete start practice and stop participation and allowing the athlete to decondition to see if the wall thickness returns to a more normal level can be an indication that this was just adaptation and not related to underlying cardiac conditions such as hypertrophic cardiomyopathy. And lastly, as I've mentioned, athletes can have distinctly abnormal ECGs, and so it's very hard to distinguish if it's just an adaptation to exercise or related to underlying heart condition. So going on about determination of eligibility. So if we do cardiac testing and everything turns out okay, we can actually tell the athlete he can return to sport. But if there is an abnormality, we do have guidelines that help us to determine what sport that the athlete can return to and if the athlete is temporarily ineligible or permanently ineligible. We use the 36th Bethesda Conference guideline, which is pretty outdated now. It was written in 2005 and is undergoing revision now, which is a consensus of experts in the area advising on specific cardiac conditions and how it would affect the athlete's participation in sport. So they look at specific cardiac conditions and also the type of exercise. They look at both dynamic exercise and static exercise. And for example, high dynamic exercise in the lower right quadrant includes running, soccer, tennis. And for high static exercise would be weightlifting, water skiing, gymnastics. And both a high static and high dynamic component in the upper right-hand corner would include boxing, cycling, rowing, speed skiing, triathlon. So if an athlete has underlying heart disease, and if it's significant, one often has to recommend that the athlete can only participate in low dynamic or low static sports such as billiards, bowling, cricket, curling, golf, or riflery. So let's look at the guidelines for examples. One is asymptomatic aortic stenosis. They are eligible if it's determined that aortic stenosis is mild. They're ineligible definitely when aortic stenosis is considered severe and probably if it's moderate. Obviously, if an athlete is having symptoms from severe aortic stenosis, they need further intervention. Myocarditis is the second example. If an athlete has been diagnosed with myocarditis, they are ineligible. They require 6 months of convalescence to allow the inflammation in the myocardium to resolve and reduce the risk of ventricular arrhythmia and sudden death. In order for them to return to play, it's recommended that they undergo stress testing, either with echo or nuclear stress tests, to make sure that perfusion and wall motion is satisfactory, that LV function returns to normal, and that there's no evidence of significant ventricular or supraventricular arrhythmia on Holter monitoring. So using the Bethesda guidelines, it can help us determine if an athlete can return to play or if they're ineligible. And if it's a serious cardiac condition such as hypertrophic cardiomyopathy, then it's a permanent disability. It also can be a temporary disability. And here's two athletes from Boston Celtics who were screened approximately 4 years ago. And during their pre-season screening was determined that they had evidence of a thoracic aortic aneurysm. In order for them to return to play, they required undergoing cardiac surgery, which they had, with repair of the aortic aneurysm and reimplantation of coronary arteries. Both athletes were cleared subsequently to return to sport. One thing that you have to understand if you're doing screening or caring for high-profile athletes is that there can be a lot of noise around you if you're determining that if an athlete is eligible to return to sport or if they have any underlying cardiac disease. Please remember that any athlete with symptoms need complete cardiac evaluation. The medical evaluation should be free of outside pressure, and you will be pressured if you're in this situation from not just the athlete's family, the coaching staff, the GM, the athlete's agent, and the press, so that there can be a tremendous pressure while you're doing this, and you just have to drown out that noise and just stay focused on doing the best evaluation that you possibly can for that athlete. You must maintain trust and communication with the athlete at all times. It is recommended to follow the eligibility guidelines because they are very helpful and they give you direction, and stick to your decision. Always keep in mind that the athlete, if you make a recommendation that they are unhappy with, they will get second and third opinions, and that's just part of taking care of high-profile athletes. So moving on to a different topic, it's commotio cordis, which means commotion of the heart. And here's a video of a 14-year-old karate athlete who is in a karate match and suffers a blow to the left chest. And as you can see on this video, the athlete collapses and goes into cardiac arrest and dies. What's important about this video as compared to the first video is in this video there was no medical team there. And the fact that there was no medical team there and they did not have the ability to resuscitate this athlete was a major factor in this athlete's cause of death. So how does this happen? Commotio cordis means it's blunt chest leading to cardiac arrest, blunt chest trauma. This occurs in athletes with normal hearts now. We're not talking about any underlying heart disease. This can happen to any athlete. And it results in ventricular fibrillation. So you can see in the photographs on the right is just photographs from that video, and you can see the fist striking the precordium of the chest, the athlete collapsing and in cardiac arrest. This is a study performed by Dr. Link at Tufts Medical Center where he used a swine model to demonstrate that with a hard projectile hitting the precordium of the swine that he could reproduce onset of ventricular fibrillation if it impacted at the specific point in the T wave of the repolarization interval of the EKG. Commotio cordis incidence, again, is related to the age of the player, the type of projectile, such as a baseball or a softball or a puck or a fist or a knee, and, of course, related to the number of participants in the sport. And so the most likely sport where it occurs in the United States is in baseball. In a study looking at the chest impact sites for commotio cordis in athletes who have suffered the event, you can see here that it was well documented that these traumatic events occur in the precordial area. And what can happen is that a source of the blow, such as a hockey puck, a lacrosse ball, a baseball, or a fist, can hit the chest near the precordium, compress the chest, increasing the intrathoracic pressure, and if it occurs in a very small time zone of the T wave, which occurs between 20 and 30 milliseconds of the T wave, that it can induce ventricular fibrillation. It more often occurs in younger athletes whose chests are more compressible. So prevention is padding on a softer ball, and the treatment is defibrillation, immediate defibrillation. So here's a good example of a successful defibrillation. This was a Little League baseball player who suffered a chest trauma from a baseball, who was in cardiac arrest. Luckily, a police car was close by with a defibrillator. The defibrillator was applied. This is the rhythm strips from the defibrillator showing ventricular fibrillation, charging, and then a shock with restoration of normal heartbeat. So simple defibrillation saved this athlete. So let's talk about automatic external defibrillators. And the key thing here is time is survival. So for every 1 minute of delay, there's a 7 to 10% reduced chance of survival. So immediate access to a defibrillator is very important. So I would recommend that any of you who care for athletes really consider having immediate access to defibrillators, whether it's on the practice field, on a competitive field. Both of these sites, it's very important to have defibrillators available. So in summary, here are some of the takeaways from today's talk. First of all, don't judge a book by its cover. An athlete can look like the picture of health, but they can have underlying heart disease and you won't know it. You must perform a comprehensive 14-point pre-participation examination. That's mandatory. If any one of the elements of that 14-point examination is abnormal or positive, then go on to perform a 12-lead ECG, and then go on to perform further testing as necessary. Refer any athlete with abnormal pre-participation examination or with symptoms for further evaluation to a cardiologist who has specific knowledge of the type of diseases to look for in these young athletes. Insist on adequate protection and precordial protective gear. Strongly recommend BLS training and recertification for coaches and trainers, for those adults who are around the field, and also strongly recommend having a defibrillator nearby. So I thank you for the time and your attention. Thank you.